Hello, my name is Jose Maria de la Torre Hernandez. I am the chief of the Interventional Cardiology Department in the Hospital Universitario Marqués de Valdecilla in Santander, in Spain. The rationale for optimal trial is very clear because left-main PCI is a procedure that is becoming very common after trials demonstrating that it's equivalent to CABG in terms of long-term outcomes. But the PCI should be done really with high quality, given the relevance of the location of this disease. Then there is a possibility of using only angiography for the guidance of the procedure, or relying on intravascular imaging, particularly intravascular ultrasound imaging. There are registries, mostly registries, and very small trials, only 2 very small trials, comparing angio guidance versus IVUS guidance, and all of them consistently suggest a benefit in favor of IVUS guidance in terms of cardiac death, MI, thrombosis, etc. But there is not really, is lacking definitely a relevant trial, properly sized, well designed, and that is the reason why we are running with optimal trial. This is a randomized trial with a target of 800 patients to be randomized to IVUS guidance versus angio guidance. And these patients are over 18 years old. They have main disease with indication for revascularization based on ischemia or even in basic examination with, for example, pressure wire. And the PCI procedure is considered appropriate by the heart team decision in the institution. Then these patients that have a clear and well-established indication for main PCI are those that we can randomize for optimal trial. Of course, we have a set of different exclusion criteria. We cannot randomize patients with still elevation MI just at the moment of the procedure, or patients with previous CABG, some other criteria like low expectancy of life that are common to these studies. We have 3 countries involved: UK, Italy, and Spain, nearly 30 institutions. And we are now, this is the criteria with the flow chart, the procedure is just to schedule the PCI and to follow after randomization the angio guidance or the IVUS guidance. In case of angiography guidance, you just do the procedure up to your criteria. And in case of IVUS, it's necessary that you perform at least, it is mandatory, absolutely mandatory, a final IVUS of the stenting of the left main. If only 1 stent, you can do as mandatory the IVUS examination of the single stent. In case of 2 stents, it's mandatory the IVUS running through the 2 of the stents implanted. And we have established optimization criteria, several targets that you have to meet in order to consider there is an optimization of the procedure based on IVUS. The potential impact is really huge because nowadays the recommendation of IVUS guidance for the main PCI is just class 2 to A, which is in favor of the usage, but is not definitely encouraging the operators to apply. And in fact, worldwide, the penetration, the use of IVUS guidance for these procedures is not really very high. Maybe in Asian countries is high, it's maybe 80%, but in Western countries, in European Union or in the United States, this penetration is between 20–40%. And it's because all over the world, people, operators, cardiologists consider there is not enough evidence. Then the impact is that in case of positive results, the recommendation could be upgraded to class 1, and the practical, the use in real practice of IVUS guidance in the PCI will increase definitely, which is a great benefit for our patients. Of course, optimal, we are close to finish the enrollment because we have nearly, not definitely, but nearly 700 patients included. We have to reach the 800 target, and we expect to do so in June, July. Then we have 2 years of follow-up because the primary outcome is established for 2 years. But at the same time that we are waiting for this, we're going to do a strict follow-up with adequate adjudication of the different outcomes of different events by properly designed committees. We also plan to perform sub-analysis that are going to address several aspects. For example, what are the best criteria for optimization? What was the prognostic weight of the different criteria we have used? The differential effects of IVUS guidance according to the lesion location in the main, distal, ostial, and IVUS derived predictors of outcome. Then the next step is finishing enrollment in June. We expect in June, maybe July. Then 2 years follow-up, good follow-up, strict follow-up without losing patients, and then prepare the main manuscript and also work on different sub-analysis. I think the Optimal is going to be an important landmark trial, building really the evidence for the use of imaging guidance in complex PCI. In this case, it's for lead main, but there are other trials, like for example, like Achievement, that are addressing the same issue, but for other complex lesions like calcified lesions, osteal lesions, other bifurcations, non-lead main, CTOs, etc. Then it's an important trial that is part of a building that is intended to support and to give strong evidence for intravascular imaging guidance of PCI, particularly in complex settings.